At first, I would like to thank you very much for giving me the opportunity to share my research project in this important initiative for young researchers. I am here to present you my doctoral research. It has to do with the implementation of trauma-focused cognitive behavioral therapy to unaccompanied refugee minors in Greece. It's a study protocol of a randomized controlled trial. Okay, just a moment. Okay. It's in the Department of Psychology at Padin University of Social and Political Sciences in Athens, Greece. It's conducted by me. I'm a psychologist, cognitive behavioral therapist, trained in the TF-CBT protocol from the University of Ingolstadt in Germany, under the supervision of Assistant Professor of Clinical Psychology, Mrs. Vasiliki Yochidi, at Padin University. The main idea is the training of Greek psychologists working in accommodation centers in Greece with unaccompanied refugee minors, and the implementation and evaluation of the intervention for the more effective management and treatment of post-traumatic stress symptoms in refugee children and adolescents. The study has been included in the Mental Health Hub program of SOS Children's Villages of Greece, in cooperation with the General Secretariat for Vulnerable Persons and Institutional Protection of the Ministry of Immigration and Asylum of Greece. The Mental Health Hub program is a program that promotes and supports the mental health of unaccompanied refugee minors, as well as enhancing the skills of mental health professionals. But let's take the things from the beginning. Unaccompanied refugee minors experience significantly more traumatic events if we compare them with adolescents non-refugees or refugees that are not separated from their families, because family has the role as a buffer against stress, as a protective factor. And here in the case of unaccompanied minors, this factor is missing. So we have high rates of PTSD, depression, anxiety, and significantly high severity of these symptoms. So we speak about a quite vulnerable group of refugees. At this point, I would like to mention that the experience of traumatic events doesn't necessarily mean that we will have PTSD symptoms or PTSD diagnosis, because there is an important percentage of children that develop mental resilience. But my target group, though, is children with a PTSD diagnosis or severity of symptomatology. Although we have a quite vulnerable group with great needs, there is a lack of good practices and training programs. Here in Greece, a country that serves as a destination or a transit point for a significant number of refugees, there is a notable absence of specialized psychologists working in the field. The majority of them are inexperienced recent graduates from the university who a lot of time don't know what to do with trauma, so most of the time they don't touch it at all. So trauma-focused CBT, the therapeutic protocol of trauma-focused CBT, could address this gap, and the evaluation of this therapeutic protocol, this approach, is the key focus of my research. I will tell you some things about the protocol. It's a comprehensive treatment model, quite brief, 12 to 15 sessions. It's culturally informed, very important in the case of refugees coming from diverse cultural contexts, backgrounds. It's evidence-based therapeutic model for children and adolescents that aims to reduce traumatic symptoms. Empirically evaluated, mostly with sexually abused children, but also with children with multiple traumas, and also applied to children who have experienced other types of traumatic events. It's a modular hybrid approach. And here you can see briefly the modules of this protocol, session by session. At first, the four first modules, psychoeducation and parenting skills, relaxation skills, affective modulation skills. cognitive coping and processing skills consists the stabilization phase, which prepare the child for the main part of the treatment, which is the trauma narrative. This is the intervention phase. After we have trauma narration and cognitive processing, in vivo mastery of trauma reminders, conjoined child-parent sessions, and enhancing future safety, something like relapse prevention. This is the integration phase. As you can see, the protocol is addressed to traumatized children and their parents, the family, but it can be adjusted in the case of unaccompanied refugee minors without the presence of the parents or other adults. It's the world's most researched treatment protocol for children and adolescents with PTSD, with studies in USA and Europe, but also in countries like Zambia, Congo, Tanzania, Cambodia, Japan, and Jordan. Something that proves the cultural sensitivity of the protocol and the flexibility of the protocol. However, in the field of refugees, in the unaccompanied refugee minors, we have a few studies, mainly uncontrolled trials and pilot studies with small sample. Usually we see case studies, no randomized controlled trials, and no research focused on the population of unaccompanied refugee minors. So we need further research with control conditions, possibility of follow-ups, a larger number of unaccompanied minors. And this is what we will trying to do with our research. The hypothesis of the research, unaccompanied refugee minors in Greece with PTSD symptoms participating in the TF-CBT protocol will have significantly reduced PTSD, depressive and anxiety symptoms, significant improvement in their psychosocial functioning and fewer behavioral problems after the end of the intervention compared to unaccompanied minors in the control group. And this improvement will be maintained 3 months after the end of the intervention. Usually the follow-up is scheduled in a period of 6 months, but in our case, it's more safe to set it in 3 months because of the high turnover of the children. It's more possible to have them still in the accommodation center 3 months after the end of the treatment for a last assessment. A few words about the methodological design of the RCT. As I said before, we have the collaboration with the Mental Health Hub program of SOS Children's Villages and General Secretariat for Vulnerable Persons and Institutional Protection of the Ministry of Immigration and Asylum of Greece. And they gave us, this cooperation gave us the opportunity, the access to go to the accommodation centers all over Greece, where unaccompanied refugee minors live, and we thank them a lot for this. And these accommodation centers was stratified, randomized based on stratified sampling according to the geographic area located and the number of psychologists who staff each accommodation center. We designed an RCT, randomized controlled trial, single-blinded, pre-post design and between intervention group and control group, and with a follow-up over a period of 3 months. It's an outcome research. We will compare the trauma-focused CBT protocol with treatment as usual with minimal intervention. This is a routine clinical management and non-directive supportive conditions. And of course, we have the randomization of the sample of the unaccompanied refugee minors. Every second unaccompanied minor with PTSD or PTSD symptoms assigned to the intervention group. So our sample consists of unaccompanied minors with PTSD symptoms, and the criteria for participating in the study is to be under the age of 18, to be diagnosed with PTSD or to have severe symptomatology of PTSD, and to have as stable living conditions as possible throughout the program. Ideally, we want 15 to 30 children in each group. It's not very easy, as you will see later in my presentation, due to high turnover of the children, but also of the trained psychologists. The research is divided into two phases. The first one has to do with the training of the professionals, where we have a 2-day intensive training on TF-CBT for the intervention group and an info session about the procedure for the control group. And the second phase has to do with the implementation of TF-CBT to a randomized sample of unaccompanied minors versus treatment as usual for the control group. The first phase is the training of professional. Here you can see the assessments that we have for the professionals, the baseline, post-training and post-prevention at the end of the program. We gave them some self-report questionnaires, demographics, professional quality of life scale, work and meaning inventory, and knowledge and skills questionnaire about trauma and trauma-focused CBT. And the second phase, the implementation phase, here we have the assessment and diagnosis of unaccompanied refugee minors, which is made by psychologists through clinical interviews and the CATS questionnaire, Child and Adolescent Trauma Screen. After we have the randomization of unaccompanied minors, information about the program and written consent from the children. The first assessment with self-report questionnaires, baseline, trauma-focused CBT for the intervention group, a treatment as usual for the control group. Again, the second assessment after the end of the treatment with self-report questionnaires, and in the follow-up 3 months later. Here you can see the assessment of the children with the self-report questionnaires, child and adolescent trauma screen, depression, anxiety, stress scale, physical symptoms, strengths and difficulties questionnaire, and WHO well-being index. And also we will have some qualitative data through a summary of the treatment process at the end of each session to identify any differences in implementation and content compared to the original trauma-focused CBT protocol. I have to say about the clinical supervision also. The intervention group has a 2-hour supervision every 2 weeks, where we share the treatment progress, we discuss and manage of difficult treatment points, and we give more detail, we made a more detailed analysis of each module of trauma-focused CBT, details instructions for the implementation of each module, cultural considerations, developmental considerations, clinical challenges, very important, and how to manage them, and sharing of additional information material. The control group has also a 1-hour meeting every month to share the progress and discuss every challenge. Of course, there is a support every day for the psychologists who implement the program, not only in these 2 hours of the supervision. The stratified random sample, the experimental group and the control group, the evaluation pre-post, the intervention and follow-up ensure the validity of the assessment because it allows the comparability of the results and consequently allows to show whether the results are due to the intervention or other external factors or common therapeutic factors. I would like to finish my presentation. I will give some detail about the progress of the research so far, some numbers. We start with 22 organizations with 67 accommodation centers and 139 psychologists in total. And after 3 informational meetings, we end up with 21 organizations and 114 psychologists who declare their interest, their participation, and gave informed consent. After the random assignment, we have the intervention group with 60 psychologists and the control group with 54. After the training, we have 45 psychologists had the training and 42 in the control group. Right now, we have 26 active psychologists in the intervention group and 17 in the control group. If you look at the numbers, you see how gradually decrease. This is because there is a high turnover in the psychologists, as I said before, who staff the accommodation centers. But what is important for the study for us is the total number of children who participate in the program and the number of comprehensive treatments at the end of the program. So, as you understand, this is a work in progress. Until now, we have, don't see very well. You see here how many therapists we have now in progress. We have mainly unaccompanied boys, 15 to 17 years old. We have 2 training groups in trauma-focused CBT until now, and very possible to have another one because new psychologists are now in the accommodation centers. So it's a work in progress. And of course, the challenges in the study. As you can imagine, this is an ambitious project plan with a lot of challenges to deal with. From the side of unaccompanied refugee minors, we have mass departures from accommodation centers due to coming of age, or informal departures, or family reunifications. Many children work informally and are absent from the accommodation centers most of the day. There is an issue of substance abuse, unfortunately, and this is a common thing among the unaccompanied minors. And there is a mistrust sometimes towards the psychotherapy process and the role of psychologists, and unwillingness to participate and drop out. Sometimes they misunderstand the therapy process with the process of asylum, because they have also there to speak about traumas, and they think that in therapy they have to do the same. So we have to, the psychologists have to explain very well what is the difference. From the side of interpreters, there is a difficulty accessing interpreters, resulting in inconsistent frequency of sessions. Sometimes there is only one interpreter who speaks Somali, for example, and this interpreter has to go every day to different accommodation center to provide his services. So you can imagine how difficult it is to have a session, a therapy session every week. And from the side of professionals, there are demanding working conditions in the accommodation center. Sometimes we have long delays in payments, or the psychologists, a lot of times, they are not only psychologists. They don't have only a clinical work to do, but for example, maybe they accompany the child to the doctor, for example. And as you can imagine, this can affect the therapeutic relationship or the therapy process in general. Also, there is a high turnover among professionals in accommodation centers due to these working conditions. But what we're trying to do is to adjust the study to the real conditions of accommodation centers, to the real thing, not in the laboratory. It's not a study in the laboratory. So we're trying to adjust our study in these conditions here in Greece. Also, it's a study without a funding, at least until now. So that's why I think this webinar, these initiatives like this webinar, is very important in order to exchange and share ideas between us. Because if there's no funding, we have to try to find alternative ways and ideas to proceed with the study. But let's say some positive things also. The first indications are very positive. There is a consistency and motivation for those psychologists involved. There is a positive response of the children who finally participate in the program to the therapeutic protocol. The treatment protocol, it's applicable in the context of the accommodation centers. There is a great possibility to expand the sample from September. Our study, we expect to contribute to these things, to the promotion of mental health and reduction of psychosocial problems of the refugee youth population. The positive contribution to an important global mental health and social problem. The strengthening the training opportunities of health professionals working with refugees. Connection of clinical work with empirical evidence in the field of public mental health, and the promotion of effective therapeutic services for children and adolescents with increased psychosocial needs. In conclusion, unaccompanied minors have increased needs due to multiple traumas and the absence of a family support network. Several of them will be diagnosed with PTSD or have related symptoms, yet there is a lack of guidelines and best practices for these cases. Trauma-focused CBT could fill this therapeutic gap because of its documented cultural sensitivity, reliability, and effectiveness. And it's very important to conduct an RCT like this to check its effectiveness in the population of unaccompanied minors in Greece. Our next steps are the consideration for program extension, because we need more time to collect the data, the exploration of funding prospects, anticipating the post-September landscape, the prospective scheduling of a third TF-CBT training program with re-randomization, of course, of the psychologists and the children who are going to participate, and of course, the training for control group who wait to take also the training. This is the motivation for them after the end of the program to have also the TF-CBT 2 days intensive training. This from me. Thank you very much for your time.